So first of all, with any UKR, particularly on the medial side, very few of us actually have ever done lateral side UKR, though it's not very uncommon. We need to choose a good implant. The robot comes next. It's the good implant you need to choose and then see whether you can actually do robotic. So if you have bad design, robot will not bail you out even if you try and put it in a good way. So make sure you have enough sizes. The recent problem I'm facing with what Ashish was just saying is robotic sizes. So if you just can't get off the good sizes with the Oxford. Number two, spend time in planning. That is the main thing which will keep on harping about, and be ready to change intra-op. So this didn't happen before, you see, but this can happen now. That what you're doing a virtual surgery, and if you didn't find something good, you change it. And you remain in varus. Never get a medial side UKR into a valgus. Even try and be in varus, not even to neutral. Try and be in varus. And know the conventional way too. A lot of us is like lap chole surgeons, you know, and we have forgotten how to do an open gallbladder surgery. It's the same here. Make sure you know how to do a conventional way also. And choose an implant which gives you a variety of sizes. Just now Ashish was talking about, you know, having very limited sizes. I think the problem with Oxford is not the actual medial lateral, it's the keel. Keel is the problem. Similarly, make sure and you see in this design, the keel, the peg holes are very small. So it doesn't cause that much of issue as the big keel in an Oxford causes. Also, choose an implant and know its design. You need to know that design and then see how you can actually incorporate in a metal. Choose the right candidate. As we've just discussed from the chairperson, when would you shift? If you've not chosen well, you may have to shift much more than you actually thought. Now, this is the conventional way of doing the same. Let's see how we change into robots. So you cut your tibia, then you do a sizing, medial inflection extension, you go about then and do a femur size, and then you come back and actually start cutting and milling, whatever you want to do. In robot, you start from step 7. So your steps are much less than you would do in a conventional way. You start straight away here. So in a robotic opening, what does help you? From an accuracy point of view and from a precision point of view, both ways it's going to help you out. And actually, I have grown up with UKRs for last 20 years, so I know how it's actually changing my practice. From surgeons, you have certain goals which will help you to fulfill. From the patient side, we keep harping on these points. I don't think we manage all these points, but these are being quoted as something useful. Now, rational. Why should we be using robot in our operation? The thing is, you need to eliminate steps. So you eliminate inventory, you eliminate less number of sterile surgical things. Also, you make the steps more reproducible. If you have a robot, the way I will do is the same person as the chairperson will do, is the same person as somebody in the audience will do is doing robotic. You give a conventional way and all of us probably will end up something different and a different size of poly too. We show these x-rays and we see conventional way was not bad, I can tell you this. It was not bad, it was good, but it wasn't excellent. So what we are trying to bring the conventional surgery is from good to excellent. That's where we are aiming for. Even still, if you ask me, Oxford is a very good operation, even done without a robot. So what will impact the results of UKRs? And remember, all these things we have already discussed slowly, but what will be the accuracy of implantation? This is something not yet getting it is a very useful surgery, but we want to make it an excellent surgery. And this is where we want to be sure that the robot is helping me. So first, let's go back to lab and see, is the data there for us to tell us that? This is 3 surgeons doing on 25 knees, and you can see like they are within either 2 mm or within 1 degree of each other. So all of them were quite consistent when they were doing robotic. They were not consistent when they were doing without the robot. The alignment, which is again we quote a number of times, has been very good with our robotic surgeries. Safety, is robot safe compared to a conventional way? And you can see like even after 550 cases, no soft tissue injury. So your robot actually helps you from wearing off from your specified field because it just withdraws inside your cannula. And the learning curve, that's again the question asked. So a conventional guy, how long is going to take to actually develop a robotic surgery? And the number quoted is 8. Believe me, 8 is I think too short. I'm not talking about actually getting good. So it will probably take about 10 or maybe even 15 cases, and then you know where you are. So this is one case. So when I was told to actually do this topic, I started filming this one. So here is a solid interface which you are actually looking at and then deciding what you're going to do. So this is very virtual reality. You've not done any step here. You are playing around with it. So first thing is to bring your femur down to your the yellow line which you see, which is the bone level. So you bring your femur down, match it with the curve also. So you shouldn't be flexing and extending too much. So the default position is 45. Then you start flexing and extending and seeing, are you able to match to that yellow line? Once you've done that, you also see the size which should look reasonable. So sometimes we have error margins coming in. So you got to keep your eyes open too. To me, robotic UKR is a marriage between a man and a machine. Pure robot will not do everything for you. You still need to be alive. Then you come on and actually look at the tibia. You look at the gap. Again, you saw the previous speaker, Rohit, the gap was being shown. And here, the flexion, extreme flexion, I think there are some errors will come because you can't really stress the knee very well, even with a Z retractor after 90-degree flexion. So don't go too overboard with getting gaps right on the extreme flexion. So few cases, this is middle compartment arthritis. You got to be sure about that. You do your stress exercise still if you're a beginner. I know that Chris Dodd says that you don't need to do them, but I still do them. And then you go ahead and you perform your UKRs. Second case, again, a middle compartment arthritis. And this is a bit more serious one where even sometimes the ACL is deficient, but you can still go ahead and do a fixed bearing. With mobile, you might be a bit reluctant to do a UKR with a absent ACL. Again, a case. So you can keep on showing these cases, That is not the issue here. The issue is, are you able to replicate your cases, each and every case? And that is what is important. And I think that is where the robot is helping you to do medial unicompartment. So as I said this, choose a good implant, enough sizes, plan, use your robot, but know the conventional way also. If you know that, you will get good knowledge, you will know where to go to, and then you will have the balance in your judgment how to perform a unicompartmental knee replacement. Thank you.